of the patient. No? So you will know that even at the psychiatric history, there is the chief complaint there. No? So you will know already, I told you that you have to verbatimly, you write down when you ask, why are you here, or why did the patient has been brought here, no? So according to the patient, which is verbatimly, if you will ask their chief complaint, you will ask, why are you being brought here, or why are you here? And the patient will tell that, ambot hiraman tagdara akon. So you have to write it down verbatimly. But you also have to ask according to the accompanying relative or significant others on the chief complaint. So you can already identify when the patient comes to you the next time that, oh, the patient, so the next time the patient comes to you and is already not psychotic or not grossly psychotic, and he will tell you that, I am coming here for treatment. So there's already a change of the patient's thought that she can already relate, relevantly. So likewise, in the mental status examination, that is deeper, because your mental status examination, and in the hospital, it is like in other department, it is like your progress notes. So at the first time, the history comes from the patient. Now, from the relative, psychiatric history comes from the relative, from the patient, and significant others. Whereas your mental status examination comes from the observation of the doctor or the clinician towards the patient. So we also have the outline. So parang it is your mental status examination, you can see how the patient improves. So as I've said, it comes from the clinician, your observation. So however, there is an outline. So the first one is your general description. So that is the appearance. So on the description and the appearance, you will take note there, the appearance of the patient. Of course, you have to take note that the patient is clean or the patient is dirty, the patient is restless, the appearance of the patient, the patient is very, what you call that, tall, clad in, as appropriately dressed. So you have to describe the patient as a whole, general appearance of the patient, whether the patient is dirty, long nails and very dirty, the patient is wearing anything, long hair, even if he is a male. So you have to write there the appearance. And also whether the patient has, what you call that, scars, because the scars is very significant, especially when the patient committed suicide or he has an attempt to commit suicide. That would be included in your appearance. So another is your overt behavior, and psychomotor activity. So whether the patient is stooping, whether the patient keeps on giggling, whether the patient is having some sexual behavior, whether the patient is very behaved. So you have to write it down there, overt behavior and psychomotor activity. Then the attitude. Attitude is if the patient is very cooperative to the clinician, whether the patient is easily irritated, whether the patient is silent when they are being asked, the attitude of the patient towards you, whether the patient is angry or is mad at you whenever you have to ask them, even their names, that is attitude towards the clinician or towards you. when you go to the department, no? As a medical student. So these are the general, what you call the general description. No? Then you have to go to the mood and affectivity. Mood. What is mood? Mood is sustained internal emotional state of a person. No? So that is mood. And then affect. Affect is the external emotional display of the internal aspect of the patient. So mood, meaning to say, is a sustained, what you call that, sustained behavior or any feelings that the patient had. That's mood. For a week ago, affect is what you see on the face when you are already interviewing the patient. That is affect. No? External emotional display of a person, of a patient. Mood is internal. No? Sustained internal feeling of the patient or emotion. No? Affect is in front of you when you see the patient. Appropriateness of affect, for example, mood. The mood of the patient, as I've told you, is sustained, meaning to say it has been there for a few weeks, no, a few months. The mood of the patient, for example, in the family, they have somebody in the family is sick, so, or having a cancer. So the members of the family or the patient that comes to you should have some sadness, no, they're not so happy, no. So you have to, the affect must jive with the mood. So the affect must also, you may say that the patient is sad, no. So if the affect is sad, the mood, the fact that the patient is telling you that we have somebody is sick in the family, so, and he is sad about that, especially if it's the mother, the fathers, or the sisters. So, if the affect jives with the mood, it is an appropriate affect. So, that is mood and affect. So, let's go to the speech characteristics. So, speech characteristics, sometimes the patient is very talkative, no? Is very valuable. To say there are so many words that he will share to you, no? Very fruitful, no? Of what he is telling you, no? Others sometimes does not say anything, no? So he lacks some cooperation, no? He doesn't say anything, no? That is speech characteristic, voluble, no? Sometimes patient is silent. That is speech characteristics, no? Then perception. So when you say perception, you have your hallucination, meaning to say perception, you use the five senses, no? Hallucinations. There is your somatic hallucination. He feels that his body is misshapen, no? Then you have auditory hallucination. He can hear something, no? Visual hallucination, no? Tactile hallucinations. So when you say perception, you use the five senses usually that you have, no? That is hallucinations. What else? Illusions, no? So hallucination is in auditory, you can hear that something, you can hear something, but actually that is just your thought, no? That is a sign already of psychosis, though it's not a grossly psychotic characteristic yet, no? So tactile, as I've said, that some small insect is usually crawling in your skin. That is a sign of an organic psychosis, like, for example, or are taking drugs. That is tactile hallucination. Visual hallucination is usually the result of organic diseases, no? For example, you have your taking also drugs, organic, no? That is visual. Auditory hallucination is usually when you have your psychiatric diseases like schizophrenia. They usually have auditory hallucination. Then you have also that hallucinations wherein the person will say that I can smell like when it refers to smell, no? Usually it is a primitive aspect of your hallucination, and it is very difficult to treat. It is very remote when you say you can smell something, no? Because it is said that the smell is goes to the characteristic of an animal. No? For example, the dog, they are being used to smell drugs. So when the patient is having that characteristic that is primitive and that is very remote and that is very difficult to treat when the patient has already that a smell characteristic of hallucination. You have another illusion. Illusion is distortion. For example, of an object. For example, you ask the patient, what is the thing on front of you? Example, a wall of cement wall, and they will tell that is a paper. That is illusion. How about delusion? Delusion is not considered as perception. No? It is a thought content. No? So you have there two kinds of your thought content. You have the thought process. Then you have, as I've said, thought content. Thought content means what is really the patient, the content of his thought. Thought process means how the patient talk to you, relate to you, the flow of his conversation. That is the thought process. An example, as I've said, of thought content is delusion. Another thought content is preoccupation. So whenever you ask the patient, he is always sexually preoccupation. That is a thought content. Thought process is looseness of association. That is an example. What else? Word salad. That is another thought process. Word salad meaning that is a mixture of words which sometimes mostly you cannot understand. For example, word salad. What is the name of you will ask the patient, where did you go? The patient will tell you that tomorrow I will go, my mother is so many things. It is a salad. So that's why it is a combination of many words. That's why you call that thought word salad. So that is an example of a thought process. In your book, you can see that an example of thought process and thought content. But I would just like to stress to you that delusion is not perception. Delusion is a thought content, and what is delusion? It is a false fixed belief. When we say false fixed belief, for example, I will say, I am the Messiah. So he believed himself that he's a Messiah, but it is a false. No matter how you try to tell them that you are not the Messiah, they will still insist that he or she is the Messiah. We have a patient on the ward before, so he considered herself as, I am Mama Mary. So no matter how you try to tell them that you are not Mama Mary, he will really insist that he is Mama Mary. That is delusion. And that is not perception. That is, again, a thought content. Okay, so there are many there That is in your, what you call that, in your book, there are many examples. Then let's go to your sensorion and cognition. Cognition, your intelligence, no? That is your cognition. Judgment, no? That is cognition. No? Then under that is consciousness. I don't know if you have been exposed to your surgery, but your consciousness there is you have different kinds of consciousness. Whether a patient is what you call it's difficult to be awakened. No? You have the term that in the surgery. I forgot the term. Whether the patient is conscious, no? Whether the patient is, you can just wake up the patient and the patient will go back to close his eyes, no? So you have to write down there whether the patient is conscious. So there are stages of that, and like in your surgery. No? So sometimes you will tell the patient is sleepy, lethargic. That's what I mean. Lethargic. When you wake up the patient will be awakened, and the patient will just close his eyes again. No? That is under the consciousness. Then you have under sensorium and cognition, you have your orientation and memory. Your orientation, you have to write there oriented to time, place, and person. But it's not that way, no? When you say oriented to time, of course, you have to write down what did you ask from the patient. For example, orientation to time. So you can ask, well, what's the time now? Or is it morning, noon, or evening when the patient cannot read? Oh? So you have to write orientation. Oh? So orientation as to time. No? Then you have your orientation as to place. So when you are in front of your patient, you're asking the patient, interviewing, having a clinical interview with your patient, you have to ask oriented to place. So how would you test the patient? The patient is oriented to place. Of course, you ask the patient whether the patient is, during your interview, is in the clinic. So you have to ask, where are you now? At the clinic, or at the market, or at the school. That is orientation to place. Then you have to have your orientation to person. So you have to ask whether who is the patient with. Of course, you introduce yourself. So who am I? You ask the patient again. And the surroundings, and the other person surrounding her, maybe the relative. So if the patient can be able to tell the host, the person, the right appropriate person surrounding him, for example, his or her mother, her father, her relative, or other significant others, and the patient know that that person is the correct one, so you have to write there oriented to a person. The first, when the patient is psychiatry ill, the first that get lost is the time. No, you can observe that even if the patient is very psychotic, they can still identify usually the person. So sometimes the relatives and even the doctor, when the relatives will tell you that, ay, doktora, they can still identify us because that is the last time, the orientation that the person will get lost, the last time that it will get lost, the person. The first that will get lost is the time, the place, then the person. And the first that will come back is of course, the person, the place, and the time. So that is the orientation. It's not just uh, a matter of just saying oriented the time, place, and person. You have to give an example to the patient, or when you write it down in your mental status that this is an oriented to time, place, and person. You write the situation. Then the memory. So you have an immediate memory. What is an immediate memory? What did you eat this morning? That is an immediate memory. No. The immediate memory is you have to tell the patient, for example, I will say table, chair, then let them follow you, let them say it again. That is immediate memory. Then you have your, another is your remote memory. I will just give you an example. There are 4 of that, no? Remote, of course, your vivid childhood memory. So you have to write it down, no? Therefore, as I've said, dimension of memory. So you just try to read in your books, but I am just giving an example, immediate and remote. There are 2 more, no? Then you have your concentration and attention, no? Concentration, of course, as in any other, you let the patient, if the patient can read, of course, you ask the patient to read and ask of what he reads. No? So, of course, you have to consider the patient's education. So, if the patient is, of course, if the patient is cannot read, how can you get his concentration? No? So, you have to take the education of the patient. No? Likewise, the attention. No? For example, attention. You will ask the patient to read, or to you give addition, subtraction, and attention if he is attentive to you. So, for example, 10 minus 5, so if he's attentively listening to you, so he can answer. But as I've said, you have to ask the educational background of the patient. That is concentration and attention. You just read, let the patient read, but consider first the education. If they do not have that, maybe you can give another example which do not need an educational background. Just give him an example of attention, wherein you will just show something, and then you will ask, what did you give? No, that is an attention. But kasi if the patient is very psychotic, or grossly psychotic, they are not attentive, no, or manic, no. So the patient will not listen to you. They're easily distracted. They can easily be distracted. No? That is concentration and attention. Then reading and writing, so you know that already. That is very self-explanatory. You read let the patient read, write, no. Then you have visual spatial ability. Visual spatial ability, this is usually given. You can find this when you rotate in psychiatry. This is what you call the evaluation or the assessment whether the patient has an organic cause of psychosis. When we say organic cause, there is really a concrete cause of psychosis, like, for example, taking drugs, or the patient had a stroke. That is an organic psychosis. There is a cause. So visual spatial ability, this in the department, you will be shown different figures of in a cardboard, and you will let the patient, you will show it to the patient. Then the patient will have to draw or take note of that different shapes. And for example, in the cardboard, the patient, the shape there is what you call the circle, and they will draw something not that kind of shape. So there must be something wrong with the patient organically. No? That is vicious spatial ability. No? Then you have your abstract thought. No? So all of you know what an abstract, no? That is concept. In psychotic patient, usually they have a permanent, no? They can't do an abstract thought. No? An example is you show a ball pen, you show a pencil. So you ask the patient, what is the difference between that ball pen and a pencil? Usually in a permanent, no? A psychotic patient, they will just say, oh, the color of the pencil is yellow, the ball pen is transparent. But if they can abstract, no? So they will tell you that the ball pen cannot be easily erased when you write it, but the pencil is easily erasable. No? That's abstract thought. No? And then you have your information and intelligence. So here you also consider the educational background of the patient. You might be asking information. Maybe they can answer, is there barangay captain, the president, because it is a common language on the streets that the president is like this and like that. But you go to a more informative or an information that the patient will really, you will really know that the patient is psychotic. So information, for example, who is the priest in their area, no? Who is the teacher of her daughter, no? So you have to ask to the SO, to the significant others. Intelligence, of course, as I've said, maybe you can also give an example of an addition, 100, minus 50, 50, minus 20, but according to their education also. So in this aspect, your concentration and attention, as well as information and intelligence, reading and writing is very important with your educational background of the patient. Okay, by income, you might be asking the patient to read and write, and the patient is illiterate, so you cannot get what you want to know from the patient. So, but however, as I've said, even if the patient is very psychotic, you will do not force the patient to do this. Because why? You might be boxed, you might be harmed by the patient. So you can have a mental status of the patient, even if the patient is running around, even if the patient is shouting, you can have a mental status examination. So it doesn't mean that when you are being told by the clinician, no? By your mentor, no? In the department, okay, you get the mental status of the patient, and the patient is running around, and the patient is talking, and the patient is shouting, you can still get the mental status, even if the patient is silently sitting down. No? So you can still get the mental status of the patient. No? So it's not that you have to force the patient in order that you can take this sensorium, their sensorium and cognition. No? So bear in mind again that even if the patient is shouting, even the patient is silent, if the patient does not answer you, you can still the mental status of the patient. So let's go to impulsivity. What is impulsivity? That is your drive. What else? Control. What is
Doc question.
that
Hello,
is,
Doc.
can you say, can you make your voice louder? What is an impulse?
Flight of ideas, Doc. Is it an example?
Yeah, what is an impulse? Diba, I've said it's a drive, no? It's wherein you can control, no? A patient who is psychotic has difficulty in controlling themselves, no? Especially when they are very violent, no? So impulsivity, even also our when we are our anger, no? Impulse, easily impulsive. So you write there, poor to moderate, poor to fair, impulse control. Meaning to say, even if the patient is, you can talk to the patient and the patient is taking medication, but you cannot say that his impulsivity is very good. Because your impulsivity there, she can control himself or herself because of the medication that she is taking. So you cannot say that his or her impulse is good. So maybe you can write there, impulse is moderate, fair, no, for the patient who are taking the medicine. But if the patient is very violent, so you can say poor impulse control. So that is impulsivity. No? Then you have your judgment. No? Judgment is when you ask the patient and what the patient will do in an imaginary situation. For example, you will ask the patient, if you are in a movie and there you can see there's smoke coming everywhere inside the movie, what will you do? In an imaginary situation, that is judgment. Then another is your insight. In insight, you have your intellectual insight and you have your emotional insight. So insight means whether the patient knows that he is ill, but as I've said, you have intellectual insight. When we say intellectual insight, the patient knows that he is sick, know that his illness is schizophrenia, know that his illness is alcoholic depression, but he does not submit for treatment or for consultation. That is an intellectual insight. Because many of our patients, especially intellectually, those who are graduated, those who are professionals, most of them know that they have an illness. Sometimes they will just, self-medicate. That is an intellectual insight. Then another, you have, as I've said, emotional insight. So when we say emotional insight, that is the patient knows or knew that he is ill and he submitted for treatment, for consultation religiously. So that is the difference between intellectual insight and the emotional insight. So insight means that the patient know that he is ill. But the difference in the emotional insight, the patient will submit for consultation, will submit for treatment, but intellectual insight, the patient will just tell you that I am sick, but he will not submit for any consultation. So that is the difference between the two. Then you have your reliability. No? So in here, you cannot really say, especially if the patient comes to you for the first time, you cannot just write, wow, 90% reliable. No? The patient, especially if the patient is, you feel that he is relevant, he is very cooperative, but only to find out that, as I've been telling you before, that what he's talking is all the delusional aspect of his mind. No? All the delusional thought that he is relating to you. Only to find out when you ask the significant others, what the patient is talking is not the truth. No? They are having just a delusional thought. So he keeps, you will be asking them, I am a teacher, I have this and like that, I'm working in this field, only to find out when you ask the significant others, all is not true. All are not true. No. It's not true. So you have to, in order that you can get a reliability, you have to have a follow-up with the patient. But on the first time, you cannot say even if they answer you, unless you have there the significant others. But still, you cannot say that it is 100% reliability. Maybe if there are significant others, you can write there only maybe 85 reliability. Because sometimes even the family does not know what the patient is, of course, having in his mind, in her mind, because sometimes the family, they try to evade their patient and they're not being accepted. So most of the family will only become aware when the patient is being brought to the department, and they will say, it's only now that he was able to know that, as if he is sleeping, he can sleep all the whole night, only to find out that he's just lying down wakefully. So even the family members does not know that the patient is having this problem, only to find out that when they brought again to the patient to the hospital, to you, when you become clerks, that the patient cannot sleep. But actually, the family or relative will tell you, Doc, he can sleep the whole night. Because he can sleep in a room, he's very silent, only to find out that he is awake the whole night. So until sometimes that he is already violent and becomes psychotic. So the reliability is very, this is what you call that, you cannot rely really even if there are significant others, because they are not all aware of what the patient is telling. Sometimes they are telling lies to their caregiver, to the relative, unless you are the one who will interview the patient clinically. So when you have your mental status examination, unless it's very important, you let the significant others go out and just tell them, ma'am, can you please go out? I will just call you when I need some confirmation about the information that the patient is talking. So at least you have the balance of from the patient of information and the balance of the information from the caregiver. So this is your mental status examination. Again and again, I'm telling you that even if the patient is silent, even if the patient is violent, you can still get their mental status examination. And mind you, when they come back, you will already find another information in your mental status examination. No? So your psychiatric history comes from the patient. It's subjective. Your mental status comes from you, from the observation of the clinician, and it's an objective findings because you see the patient. The psychiatric history, of course, you do not know what really is the truth also. But at least in mental status, you see the patient, and it is the current, no, thinking of the patient. It's a current, you know. So your psychiatric history is the information previously. You know? So that is the difference between the psychiatric and the mental status examination. So we have taken up, no? So maybe before your bimonthly is November 16? When is your bimonthly?
Yes, Doc.
16?
Yes po, Doc.
Yes, Doc.
So, together with your bimonthly is your first quiz. I will just combine your first bimonthly in Canvas. It's in Canvas, or I have to go
Opo.
to
Yes.
Canvas, Doc.
Okay. So I will give both the first quiz and your first bimonthly. I still take up the different psychodynamics in psychiatry by Erickson, by Freud, and other psychiatrists or psychologists who contributed, no, on psychiatry, no. So we still have before 16, I think, 2 meetings, and then we will have your Canvas. You please text to me what time is your schedule of your bimonthly, so that I will also know, and we can maybe if you have time and some other time, we can have your examination not during the time of your schedule of your bimonthly. If you are very busy, if you have so many heavy subjects, maybe we can have it on another schedule. No, it's up to you, but we will have that in Canvas. So let me know in advance the schedule, the time, and if you would want to change the schedule. So, okay? Okay, so, okay. So, thank you very much for the being around, for those of you, and we'll have 1 or 2 more meetings before your bimonthly examinations. So, okay? Bye-bye. Have a good day.
Thank you, Doc.
Thank you, Doc.
You will get the soft copy now?
Yes, Doc.
Yes po, Doc.
Yes, please please, yan, we will give them the soft copy of the outline of the mental status.